Now, the big question we want to discuss, and Sam brought this up as one of the main barriers to cancer screening, infrastructure. Can infrastructure keep up with innovation in early diagnosis and cancer screening? And also, very importantly, who needs to be accountable? I mean, Harpal, it seems when we talk about infrastructure, it gets incredibly complex depending on which country you're in, because it differs so much from country to country, right?
It really does, and I think, you know, when we think about infrastructure, of course, it has a multiplicity of different components to it, and as you rightly say there, Caroline, the issues with infrastructure are different in different countries. And you know, frankly, to the straight question, can infrastructure keep up? I would say currently it's not keeping up, and we need to do better. So if I talk, for example, about the UK, the issues with infrastructure are really about diagnostic capacity. We don't have enough scanners. We don't have enough radiographers and radiologists. In other countries, it might be more about financial access. So first of all, we have to understand what the infrastructure barriers are in each country and think about how we address those. Clearly, we need to think about the finances. Screening programs get applied to millions upon millions of people. And so that does have a financial implication. Some countries care more about cost effectiveness than other countries do, but clearly that's an issue. But we also need to look at the overall impact on a health system budget and how we make provision for the upfront costs of screening, bearing in mind we would expect to see savings downstream, and how we construct those sorts of argument. And then I would just home in on logistics, you know, delivery of a program that involves millions of people. Of course, we've done that fantastically well with COVID vaccines over the last year or so, but it's really not easy to do. And one needs to think about the infrastructure in communities, in primary care. One needs to think about how those are organized, whether, you know, for example, if you take a blood test, is that going to be done by your primary care doctor, or do you have to go somewhere else? How do you make it easy for people to get access to it? And then finally, when you're doing something at this sort of scale, you need really good IT systems so that you can make sure that they're delivered effectively and you can keep track of what's happening. And again, in many health systems around the world, the IT systems are not as advanced as they are in many other industries. And so we really need to make progress there as well.
Harpal, obviously, you raise a lot of very, very important points here. Ebba, weigh in here, because you all too have a deep understanding of the disparities in infrastructure in terms of cancer screening across Europe. What stands out to you?
And what stands out, of course, I think what Harpal said summarizes a lot the differences. But I think one other aspect that stands out is also the training capacity of the resources in terms of people working also with the follow-up from screening. I can give an example from Sweden, for instance, where we have now had universal screening for mammography and so for many years with very successful programs. Still, about 20% are not coming to screening. So also, how do we motivate? That's also a question related also with a kind of an infrastructure. But also, I think when we started implementing screening program for colorectal cancer, so one thing was that the state then came with the recommendation for the responsible regions to implement. But then it's been taking 10 years to get somewhere, also because of the fact that we didn't have enough trained to actually follow up with the diagnosis. So from one thing is to do the self-test at home, but then have you enough trained to do the colposcopy and other things. So again, back to how do you actually plan to have the capacity in your system, so once you can deliver on the promise of a screening program. I think that's also to weigh in and sort of plan ahead in the countries for when we have the opportunities now through new technologies to screen. How can we do that better?
Harpal, if I can go back to one of the points or several of the points you've actually made, and one thing sort of, you know, stands out to me in the sense that it all seems to be down to funding. Am I correct here, or is that too simplistic of a view? If we had better funding, you know, if, let's say in your case in the UK, if the NHS was better funded, none of this would be a problem. Is that too simplistic of a view?
I think it's a really important perspective, but I don't think it's the only perspective. Clearly, funding is critical, and without funding, none of what we're talking about would be possible. But I also think planning is incredibly important, and forward planning. And it's one thing that particularly in the screening world, we've not been particularly good at. So if I contrast with our host today, you know, when AstraZeneca develops a new drug, prior to the trials being completed, they're already thinking about what would it take to implement this? Who do we need to be talking to? How do we do the medical education and so on? That typically hasn't happened in screening contexts historically. And so we haven't, in advance of the evidence being ready, started to think about, well, what sort of IT system will we need? What sort of medical education will we need? How do we persuade primary care doctors that this is something important? And so something that we really need to get better at is the forward planning. But as you rightly say, funding is absolutely at the center of it as well. And having enough, and then I would say the third thing really is having enough sufficiently trained workforce of the right skills that can implement the programs.
That very much echoes what Ebba was pointing out before. And, you know, I know that both of you are generally in agreement, but I think, Ebba, one of the points that you made and that really resonated with me was that how do we motivate people to go to screenings? And I think that sort of weaves in with the planning element. How do we make sure this is going to happen in the first place? People actually go. How are you tackling this in Sweden?
Yes, I think we're trying to tackle it in new ways. I think we have to see that screening or staying healthy, it's not only apart from the healthcare system, it's all of the society. We need to engage in new ways across the sectors. It's everything from the school, the education, because what we see in Sweden, and I'm sure in other countries too, whether it's with the screening or now with the vaccination, that while doing this more heat maps of the country and looking down into smaller population groups or sizes, it matters where you live, your home address, your socioeconomic status, your level of education. That actually shows the clear correlation with if you're attending a screening program and also whether you have now taken the COVID vaccine. So tackling other issues at the same time is so important. So we need to take a more of a holistic approach and try to work with different methods for different groups. Also, it can be, of course, with the languages, but more using behavioral and communication sciences into how we could actually target good programs in the right areas where we need to motivate more people to come. And it can be more of a person-to-person approach that is needed, but also how you reach people through the social media, new ways to encourage. And it's encouraged to go to screening if you program in those sort of national population programs that you do have to optimize them, while then looking for the new coming technologies then, like as Harpal mentioned. But I think it's also about, as Dave pointed out, the awareness making in society. We need to be more accountable, everyone, for our own health, and actually if there's any symptoms, to go and to the community healthcare as well. So combining that is very important, because we see that despite having a fairly good average attending of breast cancer screening, still it's only 80%, it's not 100, and it's free of charge. And it's in many countries trying to remove barriers so that it with stigma, but the fear, we need to work with that. But also making it possible to attend a screening during your work hours if it's not a self-test, or you can do it at the convenience hour at the time. So logistics around it, that it works in society, I think, are also important aspects.
If I could just jump in here, I mean, I think that you know, there's a lot of disadvantages that have come with COVID, but I think one of the advantages that have come is some of the lessons that we might learn. Yeah. And actually there are lots of lessons that we can learn about how vaccines have been rolled out. You know, we're at just about 90% uptake of vaccinations in the UK now. So there are really important lessons that we can draw from. Well, what is it that enabled us to get to 90%, and which of those? There are many differences that wouldn't apply, but there are some things that could apply that we can draw from to say, well, how can we get to 90% levels of uptake on screening programs, and what is it that's driven that we can draw from? And I think there's some good things that we can think about for the future.
I mean, just to wrap it up, in a way, Ebba, it seems that maybe there's a seismic shift on part of the patients, on part of the population, because they now take ownership of their own health, and maybe that will motivate them to attend more screenings. But a final question to you, Harpal. Do you feel like there's too much regulation when it comes to new technologies, especially in your case with GRAIL? The US, the EU regulators were concerned about certain aspects of Illumina buying your business. Do you feel this really stands in the way of better technology?
I mean, I think regulation for screening tests is substantially different, of course, than regulation for new therapeutics, and it is somewhat fragmented around the world, and different countries have quite different approaches. I don't think it's the barrier. It's a barrier that we need to overcome. I think the more significant one is, how do we persuade health systems that this is something that they should reimburse, and what is it that it takes to get them to adopt a new technology and pay for it, frankly. And and Sam alluded to just how long it takes to undertake trials for new screening technologies. And one of the things, again, let's draw a lesson from COVID. One of the things we've done with COVID is we've been able to adopt new innovations without having perfect evidence, but the evidence emerges once we're already using it in the real world. If we could move to that sort of approach with new screening technologies, which we've never done, then I think we could move forward much more quickly, because patients are dying every day. What we can't do is what we've done in the past, which is to take 20 years to do each screening trial. So we've got to find a different approach.
Harpal and Ebba, thank you so much for this. I want to move on to our last debate,